Sir, Head of the Department, Pediatric Cardiac Surgery, Ibn Sina Hospital. I am now requesting the guests to take over their seat and moderator to commence the session. 29. Sir, উঠে যান। হুমান ভাই। This session will be moderated by Professor Dr. Kazi Abul Hassan, sir. I am now requesting the moderator to commence the session.
Good afternoon. After a heavy lunch, we are starting our 5th session. Is it 5th session? Yes. Yeah. I do request Dr. Humayun Kabir to present his paper, Recent Advances of Pediatric Cardiac Anesthesia. Dr. Humayun Kabir, please.
Honorable Chairperson, respected teachers, and my dear colleagues. Assalamu alaikum. I am going to present recent advances in pediatric cardiac anesthesia. Surgical management of the children with complex congenital heart disease become possible due to advances in invasive monitoring, cardiopulmonary bypass technique, and increasing number of skilled pediatric surgeons and pediatric anesthesiologists. New clinical and laboratory research improve our knowledge of anesthetic drugs which act on pediatric myocardium. Evaluation preoperatively. Working horse of the pediatric cardiology is cardiac imaging. 3D echo is possible in pediatric patient due to development of matrix ultrasound probe. Cardiac MRI provide accurate information on anatomy, vascular function, shunt quantification, and tissue characterization. Contrast enhanced MRI is useful for preoperative evaluation of morphology of pulmonary arteries. Consideration of the endotracheal tube. Cup endotracheal tube in infant and children is a still matter of debate. Recent evidence suggests no major advantage of uncapped tube in children. High volume, low pressure cup and micro cup provide number of advantages like low fresh gas use, reduce gas pollution, reduce aspiration risk and improve gas monitoring, reliable capnography and reduce risk of dislocation. National Institute of Clinical Excellence has recommended us USG guided central venous cannulation. Studies shown that USG guided central venous cannulation decrease the overall time required to cannulate, increase the probability of successful cannulation, and decrease the likelihood of untoward effect. Cardiopulmonary bypass. Infant and children have a smaller circulating blood volume, higher oxygen consumption rate, and often high active pulmonary vascular bed. Neonate and infant have labile thermoregulation and immune organ system. Large cardiopulmonary bypass, prime volume in infant and children leads to significant hemodilation that causes anemia, decreased oxygen capacity, plasma protein reduce, electrolyte imbalance, exaggerated release of stress hormone. But newer technology, minimum priming volume for CPB circuit allow full support in neonate. Consideration of the hematocrit. Optimal hematocrit on bypass remain controversial, particularly for neonate. Negative effect on perioperative outcome and neurological development when hematocrit less than was 20 operatively. minimizing lung injury associated with reactive oxygen species by reinflation of the lung with air, keeping the PO2 less than 150 and possibly more lower in cyanotic infant is suggested. Blood gas, many centers use PS state for neonatal surgery involving deep hypothermic circulatory arrest or combined strategies. Despite increased intercellular acidosis and enzyme dysfunction, some advantages of PS state are improved cerebral function, more homogeneous cooling, and better oxygen delivery. Relatively large circuit blood volume, these factors triggering the systemic inflammatory response. Current anti-inflammatory strategies are which reduce the stress response like steroid, serine protease inhibitors, modified ultrafiltration, and heparin bond circuit. Recent publications suggest worse outcome after prolonged exposure to low flow perfusion. Short period of DSCA are better tolerated than continuous low flow perfusion. The recommendation for DSCA are pre-bypass with steroid, anti-inflammatory agent, hyperoxygenation before the initiation of the DSCA. Ultrafiltration are conventional, dilutional, and modified. But dilutional ultrafiltration is more effective for the removal of inflammatory mediators than hemoconcentration. Advanced monitoring are TCD is a useful monitor for detecting acute decrease in cerebral blood flow velocity. Near-infrared spectroscopy is non-invasive optical technique used to monitor brain tissue oxygenation. Other neuroprotective strategies are like acid-base management, degree of hemodilation, blood glucose control, and anti-inflammatory therapies. Pulse pressure analysis is a non-invasive technique but less reliable in pediatric patients due to chest wall and lung compliance are high. Very important is perioperative use of transesophageal echo result in better surgical outcome and significant reduction of reoperation due to residual lesion. Consideration of anesthetic drugs. Newer drugs, sevoflurane and remifentanil, made fast tracking feasible in pediatric cardiac surgery. Alpha-2 agonist, dexmedetomidine, apart from its sedative properties, it provides effective pain relief with an opioid-sparing effect. Inhaled nitric oxide, prostacyclin, and phosphodiesterase inhibitor play a key role in controlling pulmonary hypertension. Intravenous immunoglobulin used as prophylactically in neonate and undergoing complex congenital surgeries. Blood conservation, antifibrinolytic, minimizing bleeding, especially in severely cyanotic and redo surgeries. Tranexamic acid and aminocaproic acid are used typically. A recent review, recombinant factor 8 used significant reduction in blood loss, but it is the last resort. Mechanical circulatory support advances are many centers are using extra pulmonary membrane oxygenation support as a reduced therapy, support as a rescue therapy for infants and children who require preoperative stabilization, failure to wean from CPB, or for those who have low cardiac output postoperatively in the ICU. Challenging subject for us, pain management. Single shot intrathecal or caudal morphine with or without local anesthetic providing superior analgesia, blunt the stress response, improve pulmonary function, reduce time for mechanical ventilator, and consequently reduce cost. Appropriate patient selection is appropriate for successful fast tracking of children undergoing surgery for congenital disease. Take home message for advances recent cardiac anesthesia are use ultrasound guided vascular access, cup endotracheal tube, maintain optimal hematocrit level more than 30, recombinant factor 8 using advanced monitoring like TCD, newer CPB and ECMO, new advanced drug like sevoflurane or alpha-2 agonist, and obviously effective postoperative pain management. Thank you all for patient sharing.
Thank you, Humayun Kabir, for presenting a nice paper. Our second speaker is Muhammad Ibrahim Khalil. Dr. Muhammad Ibrahim Khalil, please. His paper will be anesthetic management of minimally invasive cardiac surgery in children's tips and tricks. Yeah, show your tricks.
আমি চালু করব। Assalamu alaikum, Honorable Chairperson, respected panelist, moderator, and the respected audience. Today I am being honored as well as nervous too that I get an opportunity to stand in front of you to say something regarding the MICS. So my previous colleague has described the advancement in pediatric anesthesia in recent days. So I am going to present simply what the difference between midline cases and MICS cases in respect of anesthetic management. I will not go through the anesthetic management in detail in my presentation. And you know, the MICS is emerging worldwide, and different centers, different people work in it, and they work as like which is comfortable for them. So in my presentation, as we are doing large amount of MICS in our hospital, you will get actually what we are doing over here and something what else other doing over their centers. So MICS emerge as because to avoid the cutting of the breastbone, which reduces postoperative pain, you all know. And MICS involves making small incisions in the chest wall to reach the heart between the ribs. And you all know good and effective communications between the surgeons, anesthesiologists, perfusionists, and nurse is utmost importance in good outcome for cardiac surgery. So these are the fields of MICS in children. Surgeons usually do ASD closure or PFO closure or atrioventricular septal defect surgical repair, and nowadays VASD closure also, and mitral valve repair or replacement, even aortic valve replacement can be done by MICS. So why people choose MICS? You all know, as because there is no cutting of bones in case of MICS, so there is less pain, lower risk of infection, lower risk of bleeding, reduced ICU stay, reduced cost, improved postoperative pulmonary function, improved quality of life, accelerated recovery, and return to activity. And only there is benefits? No, every benefits have some risk also. So MICS has all the risks similar to the midline cases, like bleeding, chance of stroke, chance of infection, chance of arrhythmia, and chance of death. And if there is any perioperative difficulties arises, then it is difficult to manage in case of MICS because of the patient position and surgical exposure, you know. So what's the job of an anesthesiologist in case of surgery? The main target and the job of anesthesiologist is to facilitate surgery. You all know the subject anesthesiology is developed by the hands of surgeons. So the main target is to facilitate safe surgery by maintaining patient's physiology normal. This is the main job of an anesthesiologist. And is there different anesthetic management in case of MICS? There are few differences. I have shown over here that if you look for preoperative evaluation, MICS, in case of MICS, we have to look for pulmonary function adequacy or not. And we also look for these in case of midline cases also. But as because there is a small hole for surgical repair and there is ventilation is compromised, so ventilatory adequacy is more important in to assess in case of MICS. And all sorts of repairable congenital heart surgery can be done in midline cases, but not all cases done by the MICS procedure. And usually short acting drug used in MICS, because I have already mentioned that in case of MICS there is early recovery, so we can choose any inhalational agent or propofol like drug which duration of action is very limited, remifentanil, which makes the recovery in ICU or extubation is very earlier in case of these patients. And though I have mentioned that MICS emerged due to reduce the postoperative pains and so on, there is a very important issue of cosmetic purpose. A lot of patients come to surgeons to do MICS that they have heard that if a case is done by midline, there is a large scar and this makes looks bad. So they want incision which is under axilla and it will not be visible. So it's important issue of MICS, that is cosmetic purpose. So keeping this in mind, we used to put central venous catheter in the femoral veins rather than internal jugular vein. Because the position of internal jugular vein, is visible every time a patient go outward. And the special things of MICS is to provide one lung ventilation, but in case of bigger child we can do the one lung ventilation, but a smaller child it is not recommended. You all know that one lung ventilation is recommended only after 8 years of age, not before that. And in case of ICU management, all other things are similar, but we have to use higher PEEP, and why it is used I will tell you in next. So these are the patient selection. We have to avoid the patients with pulmonary hypertension and the other things which may reduce the surgical exposure, like prior thoracic surgery or external beam or radiation or any trauma to the chest wall, which may cause the pleural adhesion inside. These all are actually surgical difficulties not for us. And if we consider for the one lung ventilation, I have already mentioned after 8 years of age. In case of children, better to avoid one lung ventilation, and we can manage the ventilation in normal conventional endotracheal tube also. So how to adjust the ventilation in with the endotracheal tube? Here I have shown 2 pictures where I can show a operation data. This was a case done in our hospital in 18 January 2023. The patient name was Mehjabin and she was 7 years old and her weight was 18.6 kg. And when the surgeon make an opening in between ribs, you can see the lung tissue. So how can we visible the cardiac anatomy, which can be corrected by the surgeon, and how can we manage the ventilatory issues of these patients? So here is the ventilator setup. You can see that we used to use tidal volume close to 6 ml per kg or 6 to 7 ml per kg body weight, and we accept a higher status of EtCO2. You can see that here there is the EtCO2 is 37. You all know the difference between EtCO2 and PaCO2 is 2 to 5 millimeter of mercury. So if I consider that 45 millimeter of mercury is normal PaCO2, then we can make the carbon dioxide and oxygen tension in blood with this ventilator setup. And now you can see the 2 pictures, where in the first picture, in the left-handed sided pictures, surgeons just put a gauze on the right lung and you can see the pericardium. And on the right-hand side, you can see surgeon do the pericardiotomy and you can see the right atrium here. So our ventilatory setup doesn't make the surgeon to work difficult situation. We can manage the ventilatory issues of these patients by adjusting the tidal volume and respiratory rate along with. And special consideration as we do the femoral venous cannulation, so we should connect some additional syringe pumps to the CV catheter, because after draping we cannot approach the CV catheter. So we have connected these syringe pumps prior, and prior check of the CV catheter if there is any backflow or there is free flow of blood or not. And we have to make sure that easy access of venous canula. You can see that the cotton wrapped hand, there is a 20 gauge cannula of pink color, and there is ET tube fixation and carrying of the ET tube and position of the upper limb. You all know that the axillary angle should not be more than 90 degree. If more than 90 degree, there is a chance of brachial plexus injury. So when patient is in pump, we have nothing to do other than provide anesthetic drugs to the CPB pump. And after CPB, you can see here there is right atrial closure, and how we manage the post CPB ventilation. You can see this video is not running. So in post CPB time, we usually need a higher FiO2, 0.7 to 0.8, and try to keep ventilate tidal volume 6 to 7 ml per kg that I have said earlier, and maintain EtSO2 close to 30 to 35, adjust inotropes with retrograde dosing. If you are working in the field of cardiac anesthesia, then you can already know that the after CPB, EtCO2 and PaCO2 difference is higher. And the keeping tidal volume less is due to the helps better visualization of the surgeon. And before closure of the incision, I have shown this picture. If you have a clear view or not, there is iatrogenic atelectatic lung field over here. So after closure, we have to increase the tidal volume to 10 ml per kg, and we have to apply PEEP 6 to 8 centimeter of water to recruit the atelectatic lung. Some of us are very used to inflate the lungs by hand ventilation. It is not bad, but you have to take in mind that your hand ventilation pressure should not be exceeded over 40 centimeter of water. Then there might be a chance of barotrauma. And maintain the vitals. In ICU, apply PEEP, limit the intake, IV replacement preferably colloid, no IV fluid after extubation. Better to use reversal agent in case of children, because you all know the normal protocol of weaning is not possible for the children. And chest physiotherapy from first POD. Most of the child undergoing MICS can be shifted to ward on second POD. And in conclusion, I would like to say the anesthetic difficulty in MICS lies in the ventilator management actually. Central venous line is difficult to access after draping, and pediatric patients are not small adults. So lot of issues are there to consider, as because this is a pediatric case. So thank you all.
Thank you, Ibrahim Khalil, for presenting a nice paper. Now, may I call Nurul Hassan. Nurul Hassan presents challenges of establishing a pediatric cardiac ICU, our experience. Thank you.
Assalamu alaikum. Welcome you all, chairperson, moderator, panelists, and participants. A very thanks to the organizer for giving me the opportunity to present here, and also I would like to thank to organize this seminar. This is the first of this kind of seminar in perioperative care in Bangladesh. So I am Dr. Hassan. I am basically pediatrician, started doing pediatric intensive care, and since 2011 I have been working in pediatric as a pediatric cardiac intensivist at National Heart Foundation Hospital. So I will try to take you to a tour of puzzle and troubles in a challenging situation of pediatric cardiac intensive care. Now I am working as a associate professor and senior consultant. So this is a bad time for a presentation. After lunch, most of you are either sleeping or drowsy or busy with mobile.
No,
So
no,
I have no-
I don't feel that none of
No,
our
possibly not,
audiences
yes.
are sleeping.
I am
They are
fortunate,
attentive to
and
your
you are.
speech.
Yes, thank you, sir. Thank you. Thanks, everyone. And I have no disclosure, and I would like to acknowledge Dr. M.A.K. Azad, Assistant Professor Pediatric Cardiac Surgery, and Dr. Istiakal Manju, Registered Pediatric Cardiac Surgery, to help me to prepare my presentation by providing few slides and data of our program. And this is the beautiful picture. It was taken by Dr. Azad, the same baby before surgery and after surgery. So this is what we can give to this child, and this is what we can do to these beautiful creatures. So I'll tell you a few stories. One or two is a case of pulmonary atresia, VSD, PD-dependent circulation, who underwent a palliative procedure, pulmonary artery RB2PA conduit with a VSD kept in situ and LPRPA plasty. With a stormy postoperative course, came with ICU with an open sternum, and there was right sided diaphragm palsy. There was repeated weaning trial failure, and we plicated the patient. Diaphragm plication was done, and then it continued to have weaning trial failure, and tracheostomy was done for 41st postoperative day and decannulated on 72 postoperative day. And she had few other issues like pulmonary hemorrhage, wound dehiscence, severe hypoxia, CPR events, multiple culture positive sepsis, and ventilator associated pneumonia. And this is the beautiful picture before going home. Our next patient, a baby of birth of 3.1 kilo, when he came to our hospital at the age of 3 months 20 days, his weight was 2.2 kilo. Very large VSD, PDA, severe pulmonary hypertension. We tried to manage medically, but we failed. And then in a desperate situation, surgeon decided to close the PDA only. And during immediate postoperative period, when he was little stable, we extubated on 4th postoperative day, but video is not working again. It's happening to me also. Sorry. It's okay. It's okay. So he had severe stridor, and we had to reintubate within 30 minutes. Okay, it's okay. It's okay. So we anticipated a stormy course and repeated weaning trial failure. Tracheostomy was done little early on 11th postoperative day, and subsequently he was improving, increasing weight. He stayed in our ICU for 2 months, shifted to ward, and the day before, when he was ready to discharge home, he had a choking attack, had a respiratory failure, arrest, CPR, and died. We could not help this kid. There are stories of success and failure, which makes us disappointed sometimes. So pediatric cardiac intensive care is a distinct discipline in the Western world, but it's not in our part of the world. Although there are centers coming, new centers are coming, and any pediatric cardiac surgery program must have pediatric intensive care for its successful outcome. There are challenges. It is a stressful job working in an intensive care unit. There is no available training and teaching facilities, unimpressive salary structure, non-practicing job yet not popular in this part of the world. There is no career counseling program, no staff retention policy, very important. No career icon, and this pediatric cardiac surgical program still surgeon dominated area. So there are challenges and disputes. So as there are few centers working in pediatric intensive care, cardiac intensive care, the existing pediatric cardiac intensive care is overloaded with patients. There is high cost of care, an additional cost of long ICU stay, post-operative complications, specialized care like dialysis and permanent pacemaker replacement. And unpublished data from our hospital, we found only 26% of the cost is being managed by patient's family. Rest of the money is either from loan, relatives, philanthropy, etc. So there are substantial resource limitations, especially infrastructure, human and material resources. Maintenance and servicing of the machine, infrastructure, accessories, huge challenge. And during recent times, it became a very big issue, cost and availability of consumable. And during last few months, we suffered from availability of oxygenator. We know, everyone know this thing. So what is the way out? Acknowledgement of the real burden and need, and to acknowledge that pediatric cardiac intensive care is essential for successful pediatric cardiac surgery program or pediatric cardiac program. There must be institutional support, because this pediatric cardiac surgery program or pediatric intensive care is not a money generating project. So institution must be supportive to this program. Professional bodies and organizations, they can come forward for advocacy group to mobilize government and authorities and agencies for establishment of pediatric cardiac ICU, procurement of instruments, and also training. Public-private partnership model like National Heart Foundation Hospital can be a good example. Funding and support from corporate social responsibilities, philanthropy, improvisation, innovation, and adaptation, very important for a center like us with lot of limited resources. Continuous training program, robust staff retention policy, I repeat, this is very important. Liberty and autonomy of intensive care team. So pediatric cardiac intensive care is not just another branch, another part of pediatric intensive care, or it is not just smaller version of adult cardiac intensive care. This is a unique group of patients. They have unique requirement and need that has to be addressed with specialized group of people, trained and dedicated. My presentation would not be complete without this slide. This is a visionary national professor, retired Brigadier Abdul Malik, who founded National Heart Foundation in 1978. Subsequently, cardiac program and pediatric cardiac program was started. In 2011, pediatric cardiac intensive care was started there. And in 2016, separate premises was inaugurated and pediatric cardiac program has been shifted there. So now we are dealing all the complexities of related pediatric cardiac surgery. We have all the benchmark surgeries in our ICU, and increasing number of cases, more than 800 patients last year we managed in our ICU, 12 patients in our ICU. If you look at the mortality pattern, last year mortality is little high, and it is correlates with the increasing number of patients and complexity. And in 2020, number was less, but mortality was highest, and it is due to COVID. And other thing is 70% of our nurses quit job for the government service, and we had to work with very new staff nurses with no prior experience, even in a general ICU. We have more than 200 tetralogy fellow patients in last year, and 47 patients in arterial switch operation for TGA last year, and its number is increasing every year. Infant and neonate is also increasing, and sometimes it looks like neonatal ICU, not a pediatric cardiac ICU. So we have a diverse group of patient population, malnutrition, patient with comorbidities, and also adult congenital heart disease patients. Teenage mother, another problem in this part of the world. So we have two ICU equally equipped, 8 plus 8, 16 bed, and another ICU of 11 bed. That is, we use as a step down. So this is our manpower distribution: cardiac surgery, cardiologist, anesthesia, intensive care. And intensive care is significantly understaffed, and we get support from our colleagues from cardiac surgery, cardiologist, and especially anesthesia. They give very good support to us. This is our 4th ICU going to be started very soon. This will be dedicated for medical cardiac patients, not surgery patients. And this is our team. Nothing is possible without a great teamwork. A successful pediatric cardiac program would not be possible without a good nursing staffs. So we have few improvisation and new invention in our ICU. We have one staff nurse in each shift. They stay as a team leader nurse. They are not assigned to any bed. And we have 2 nurses in the daytime from 9 a.m. to 5 p.m. We call them nurse with special assignment. They are bridging between the doctor and nurses. This is another group of healthcare provider, intensive care assistant. They are non-nurse healthcare provider, brand new. We just trained them up for 2 months, and then now they are taking care of our patients. They take care of only patient care part. They are not involved in putting IV cannulas, injection, venesection, etc. We don't have respiratory therapists, but we trained one of our intensive care assistant as a respiratory therapy assistant. And we have few manpower for cleaning and other supportive works. So continuous training and teaching program is an important part of our care. We have boarding program for new doctors and nurses, also ongoing teaching and training programs for doctors and nurses. But there are few things we don't have till now. We don't have dynamic and active infection control program, which is fundamental for a pediatric cardiac program. Antibiotic stewardship, we have to work on it. Respiratory therapist, dietitian, nutritionist, pharmacist, and biomedical engineers. So this is the last slide. If I try to summarize, actually the list is exhaustive. If I summarize, then I should say successful pediatric cardiac program depends on pediatric cardiac intensive care with specialized, trained, dedicated group of caregivers with liberty and autonomy to work in their area. Infection control program, antibiotic stewardship, teaching and training program, staff retention policy, improvisation, innovation, adaptation, and use of low-cost technologies. Thank you.
Thank you very much, Nurul Hassan. Very elaborative and really informative presentation here. Now, I may invite Richard Hubbard, please. He will present global collaboration to improve the cardiac surgery for children's challenges and opportunities.
Thank you all so much. I'm going to talk a little bit today about what I'm doing here and why I'm here and why my other colleagues have come, and that's to improve global collaboration and overall improve care for children getting cardiac surgery across the world. I want to start with a couple of definitions. There's a lot of words that we can use to describe the same thing, but when we think about nations that have the highest levels of economic and healthcare development, we used to use a word called developed, which we don't use anymore because it implies that other people aren't developed or somehow lesser than we are. So one phrase that we've come up with is the global north, which essentially means those countries that are fat with riches. So like my country, for example, we're also fat people in general, but fat with riches for sure. And then we talk about the global souths, those nations with lower levels of economic and healthcare development. So I'll be using those terms because I think they're the best terms at this point. They're not exact terms, but it's what we're going to use for this talk. So there's a few sad truths that we all have to come to terms with in terms of cardiac care in general and cardiac care for children in particular. And that's that the distribution and quality of care is based largely on who controls wealth and who controls resources, and also on geography. It is not based on need. So the need is not being met globally. The need is being met where people have the resources to meet that need and have a motivation to meet that need. And really the primary driver of access to care is luck of the draw, where you're born, and which, you know, how close you are to the care that's provided to you. So I'll give you an example of where I come from. So this is the Texas Children's Hospital, which is in Houston. So if you're a child born in Houston, Texas, or one of the surrounding communities, and you have a congenital heart condition, you're pretty lucky, right? So this is this the pointer? How do I? Is it? Okay. So this is right here. Sorry, I don't want to get you in your eyes. This is the Legacy Tower. This is a brand new tower that we built. It's 24 stories tall. We have not one, but I'm counting them, 4 ICUs designated specifically for cardiac care for children and adult congenital cardiac care as well. When you enter the Legacy Tower, you have this beautiful atrium, and then you go upstairs to the 20th floor and you can get your cardiac cath in one of our cardiac cath suites. We have 4 operating rooms designated specifically just for cardiac children. And then when you recover in the ICU, you recover in a room like this, which is essentially like a fancy hotel room, right? And every child gets one of these. And then when you need your outpatient care, you don't have to necessarily come to the big hospital downtown, which is difficult to get to and has lots of parking issues. But we have outpatient clinics throughout the community and even in other cities where you can go to and see your cardiologist and get your follow-up care. But the thing that's really striking is that, so I live here in the southern United States. Just a few hundred miles away are people who have no access to care, or extremely limited access to care. That's places like rural Mexico, Guatemala, Nicaragua, Belize. These are places where your access to care is really limited by your financial capacity and your ability to get whatever limited access might be there. And the thing that's interesting is a lot of the patients that I take care of come from or their parents came from these countries. So it might be very true that a child who I take care of in Houston has a sister or brother living in Nicaragua or Guatemala who doesn't have access to care, and this child has access to enormous amounts of resources. So this is a child from southern Mexico, right on the southern border of Mexico. Absolutely beautiful child, and I was invited to go on a medical mission trip. So we took a group of doctors down there and performed surgeries for about a week there. And this is her after getting some oral midazolam, so she's very drunk, very much intoxicated, and very happy before surgery. And it fills your sort of heart with joy that you're able to take care of these kids and offer them a second chance at life. So that was a really uplifting experience for me. But the thing about it is this goes back to a whole history of medical missions. Does anyone, if anyone, I'll be very impressed. Does anyone know who this is? Anybody? So this is Albert Schweitzer. He was a famous, he was either German or Austrian musician in the 1800s who decided that he wanted to become a doctor. So he became a doctor and then moved to Central Africa and took care of people in Central Africa for the rest of his life. And he sort of held up as this ideal of the medical missionary. People might recognize this lady a little bit more. That's Mother Teresa, who lived not too far from here in Calcutta, who also did a similar thing. And these people were driven by a desire and an honest desire to serve those who were most in need. And many of them did build long-lasting hospitals and clinics and other institutions that exist even to today. The Albert Schweitzer Hospital still exists, as does Mother Teresa's institution. Some of these organizations help in crisis zones. We think about Doctors Without Borders or the Red Cross or Red Crescent societies, and they've helped to transform millions of lives, which is really an amazing thing. The downside of this model of taking care of people is that it's simply not sustainable, and it's wrapped up in all sorts of other cultural issues that we don't necessarily think about. So there's a real one-way relationship that's created here. So this is Albert Schweitzer in his clinic in Africa, and it's a very clear message of the father taking care of the child, right? So I'm the white father, and you're the black child, and I'm going to take care of you, right? And I'm going to make your life better, right? We've all heard this story before. It's a very old story. It also, and you know, so we imagine that we've gone away from this model, but this is directly off the Doctors Without Borders website, and it's the same image, just 100 years later, right? It's almost the exact same picture that's being presented here. It also depends on the goodwill of the giver. So if I just decide one day that I don't want to do this anymore, then everyone else is out of luck. It's also wrapped up in colonialism. So with the conquering people come the people who are going to serve you as well. So those two things are interlinked. There's a lot of relationship between medical missions and attempts at religious conversion. There's a famous quote from, I believe he was a French missionary who ran a hospital. I believe it was in sub-Saharan Africa. And he said that the best time to convert someone to Christianity is when they're on their deathbed. So it's like, it's a great opportunity for you right then, right? So to make sure you talk to them right when they're about to die and you save them, then they become a Christian and it all works out for everybody. And this is something this is a hospital that I found that's again in sub-Saharan Africa. It's a Christian hospital that claims to be performing miracles in the rainforest, right? So it's again that sense of religion mixed up with these people that are somehow other and different, right? So, and then finally, it's all wrapped up in political currents. So my country gives a lot of aid to a lot of countries to do a lot of good work, but also it comes with that kind of relationship of I'm giving you something and I expect something from you. I expect your loyalty or other things from you, right? So there's real downsides to this perspective, and it really brings me back to this experience I had and thinking about how I was perceiving this child and how I might help to improve the way that we can interact with this problem. So we do know that the need for surgery globally for children is huge. Thousands of children die each year without access to care, without ever getting care, and that this distribution heavily favors wealthy countries. And you think about a country like Bangladesh. So Bangladesh has 160, 170 million people. By the pure numbers of the number of children born in Bangladesh, you should have something like 40,000 new cases of congenital heart disease every year. And yet we're doing about 2,000 cases of heart surgery in Bangladesh every year. So we're meeting at the maximum 10% of the need. So the vast majority of children are simply not getting the care that they need here in Bangladesh. And I'll give you an example of how skewed this distribution of care is. So in the whole of Bangladesh, there's 25 pediatric trained cardiologists. In my hospital alone in Houston, there's 66 pediatric cardiologists. There's 9 pediatric cardiac surgeons in Bangladesh, and we have 6 in my hospital. So there's an enormous gap there. So what is the need as I see it? So we need to increase the number of skilled practitioners that are practicing in Bangladesh. We need to create training programs and career pathways for young doctors. One problem that we've recently recognized in America is that we're training a lot of pediatric cardiac surgeons, but we don't have jobs for them when they graduate. So just like that, we need to not only train people to do these specialized things, pediatric cardiac anesthesia, pediatric cardiac surgery, pediatric perfusion, but we have to then also give them the opportunity to have careers that are meaningful and in which they can support their families and their financial futures as well. We have to increase the distribution of care. So we can't just be giving care in Dhaka or a few places around there. We need to increase our technological capacity and training. And then the capacity of the care team. One thing that really resonated with me in a number of the talks today is how much we need the allied health profession, so perfusion and respiratory therapy, and these other types of experts that we don't necessarily think of immediately, but are critically important. We have to increase our research capacity, and we also have to fund these programs adequately. So when I think about goals of collaboration and how we can best increase the quality of care that's given, it has to be goal focused and based on need. And that need should be identified by the practitioners in Bangladesh, not by me, right? So my perception of need is it may be very different than Dr. Saleem or Dr. Rima's perception of the need. And they're probably right and I'm probably wrong because they do this every day and I just have this perception in my brain. There has to be open lines of communication and clear roles and responsibilities. So we have to be beholden to each other and be able to communicate with each other honestly in order to effectively create real partnerships. And we have to have reviews and accountabilities. Am I doing what I said I would do as a partner here? And are you doing what you said that you would do as a partner as well? So what can someone from the global north, a northerner like me, what can we offer? So one thing is money. So my organization, the Basic Needs Program, provides financial support for surgeries that goes directly to the hospitals to help fund the surgery for the specific kid and help build the capacity of the hospital. We have knowledge of new and novel treatments and procedures. So we're able to give some information about those sorts of things. We have technological capacity and knowledge. We have research capacity and training, and we have time. So whereas many practitioners all around the world are working 18-hour days with no time off, I got time off to come here from my hospital, and I don't have to pay for it, right? And so we're here and interested in being able to contribute in some way, and also image. So the connection that you might make to a very well-respected organization like Texas Children's Hospital increases the image of Ibrahim Cardiac Hospital or any other institution that might choose to partner with us. And then what can global Southerners offer? So what can Bangladeshis offer us? So institutional and geographically relevant knowledge. So you all take care of these patients all the time, and you are the experts on taking care of these patients. And so there's an enormous amount of things that you can teach us about caring for patients that have different types of disease states than we typically deal with. You have knowledge of management in austere conditions. Again, something that's really educational for us because we live in a world of all the resources we could ever want. Educational opportunities, research opportunities. So there's a lot of an amazing amount of information that we can take and learn from right here in Bangladesh, and access to the patients who are most in need. So you all the ones taking care of these patients, we want to be able to help people who need it the most, and that's through you. And then also image. So this is interesting. So I came to Texas Children's about a year ago, and now when we are interviewing new people to hire, my boss will come to me and he'll say, hey, can you go talk to them about your work in Bangladesh? Because that makes us look good, right? That makes us look important, you know? So so the image thing goes both ways as well. So just a little bit about what we do here. So we're a small US-based charity. We're focused mainly on cardiac surgery for children in Bangladesh. So we want to support heart surgeries financially. We want to provide pre and post-op logistical support, and assisting connecting families to care. So we have a network of practitioners who help send us patients, and then we send them on to the care that they may need. The other endeavors we have are a peer support program. So we have connections that are specifically made between practitioners in the US and practitioners in Bangladesh, and we want to increase those programs. So, for example, if we have a cardiac interventionalist who has a concern about a procedure, we can connect them with a cardiac interventionalist in Texas, and those two people can have a conversation over WhatsApp or video conferencing and talk about the best options for them. So the medical exchange program, so this is what we're doing right now. So this is people coming here and integrating into this experience, and then also hopefully one day people coming there and giving us their perspective as well. And then finally, research. This is something that we really want to build up, is the capacity to do research together as a group. So in conclusion, global collaboration can have a real impact on the care that we give patients, but it has to involve partnerships that are based on equality and trust, as well as responsibility and accountability. And the focus must always remain on taking care of patients for the better. I want to thank everyone for having us here, and I want to specifically thank Dr. Salim and Dr. Rejwana Rima, who are my brothers and sisters in this effort and who've been really helpful in our work with the Basic Needs Program. And I hope all of you all can get involved as well. The last thing I'll say is part of why we're here is we want to build these long-term connections. So if you are interested in connecting with us from anesthesia, from cardiology, from intensive care, come and talk to us, exchange cards, WhatsApp, group us, and we want to build this over time. So hopefully this is the first of many interactions that we have.
Thank you, Richard Hubbard. We will continue this type of programs for long, long years together. Now the floor is open for question, only few. Anyone can ask to anyone. Any question from your side?
Yeah, okay. I asked a question regarding MICS. Some patient experience too much pain during MICS. Have you any experience to use any intercostal nerve block to prevent the pain management?
Some people are using intercostal nerve blocks, but we do not use intercostal nerve blocks in our cases.
We have a little experience that if you use intercostal block by bupivacaine or lidocaine, that may cause very much beneficial to the patient.
Yes, sir, but you know that bupivacaine will cover this postoperative pain at a certain period, but after this period,
it will be given perioperative.
Yeah, perioperative. Yes, sir. This should be given in perioperative.
Another thing, Selim already doing a
I-
lot of MICS case, but do you not have done any PDA through trans-axillary route? Why not?
One twin incision.
It's axillary.
Just to your previous point, one option for pain control, which is the most effective, would be a thoracic epidural catheter, which has its own complications. It is a difficult procedure. It ends up not being helpful, right? But but one that we've talked about a little bit in our facility is erector spinae blocks, which are pretty easy to learn to do and low risk, and they're single shot blocks. And that can give you, 12 to 24 hours of pain control. So that's one thing to consider doing.
That's not that much legend to spinal block, because some patient may complain hypertension, some may go into shock also. Yeah.
Erector spinae.
Yes,
Thank you.
yes, thank you. Any more questions? Yeah. Mike, please.
I think I am some loud voice. I can. However, though it's not related to this session, I want to know, because in Bangladesh we have shortage in anesthesiologists, and it will not overcome, I think, in next 10 years also. So there's some alternative backup. Some doctors or some, not only the intensivists, some will come forward, but they may be trained up. So you have any plan to get up our professionals to junk up with all your cover?
So yeah, it would be great to increase the number of people in training, and there's a lot of interest in how we can offer educational programs, whether that's virtually or having people come and train with us, or bringing people here as well. One thing that we do in the United States that's different than a lot of countries is that we have nurse anesthetists. So we have fewer anesthesiologists who cover more rooms because we have what we call physician extenders. So I can cover 2 rooms at a time because I have a nurse anesthetist, which is one way of making up the difference. But obviously that's not true universally.
Our suggestion is that if 1 or 2 person from Texas University come here, stay for 1 or 2 weeks, and have a program thrown by our great pediatric cardiologist, it will be more beneficial. Lot many anesthesiologists from different hospitals of Dhaka city and outside will come here. They will learn better than going 1 or 2 persons to Texas. Yeah, we should have that type of plan. Thank you. Any more question? Now from the panel, Jahid, you want to say something more?
Basically, nothing to say because just I sit here to one of the great Professor Qazi Abul Hassan. He is my mentor from last 13 years, and one of the Khalilur Rahman sir. Nothing to say about this speech. Just a speech is very fine, it's very practical. Just one thing is that Nurul Hassan, he says very nicely, this is our great problem in our country. I say that without intensivist, a surgeon is like a paralyzed man. Thank you.
Thank you, everybody. And thanks to all presenters who presented very nicely and elaborately. I don't want to comment on the topics, but what I want to say, I am an adult cardiac surgeon. Being an adult cardiac surgeon, which I realize and observe that pediatric cardiac surgery is a very task job and challenging, as we are dealing with very little kids who having a complex cardiac problem and go for surgery under anesthesia. So the person dealing with these little kids should be very experienced, expert, and knowledgeable. And for the last few years or decades, the cardiac surgery, even the pediatric cardiac surgery, advances tremendously globally. But in Bangladesh, I think we are a little bit behind or in that position. So if I see the last topic, global collaboration to improve cardiac surgery for children, not only for the children, for all the people. If we get the collaboration, it will synergize our energy, our advancement, and our knowledge and expertise. Thank you very much.
I do request Professor Khalilur Rahman, ATM Khalilur Rahman, our really encouraging sir, who had started the cardiac anesthesia in NICBD. He had encouraged us to learn more cardiac surgeries, to give more time in ICU. He will put some comment here.
Thank you, Hassan. I'm very happy, and I should congratulate first Selim to organize such a program. A clap for him. This is first time someone gathered the people who works really, not to register to have the gift. He collected all the people I am seeing here, actively involved in cardiac surgery. And I'm happy, other than Sharifuz Zaman and Shamsuddin, all the practicing pediatric cardiac surgeon is here. So clap for them. to take care of the children is not easy. Even think about your children. And they're doing that tough job. Sick baby, cyanotic baby, dyspneic baby, they're taking care of them. So just I am thinking, because I am attached with these services from 1983. I'm working with the children, because when I started my career as an anesthetist, that there was no coronary surgery. Main surgery was congenital or valvular. Valvular was very good number of, because there was no PTMC now that time. Ballooning was not there. So all cases coming to us, we are doing either finger dilatation of the mitral valve or Tufts dilator dilatation or ASD, VSD top. And when it is top and common ventricle or something else, mortality is sure. So there is a good number of mortality was there. So I must remember Professor S.R. Khan and Nabi Alam Khan. With their limited knowledge, resource and facility, they are going to serve these people. They are doing, they are not here. So we did that time. That was the perfusion was very primary. There was the cardioplasia is crystalloid. Temperature was controlling rightly. Drug was not available. You can use now the vasodilator, inotrope. We have 2-3 inotropes, limited syringe pump. How to manage? That we did. We served in that time. And I appreciate again the Sharifuzzaman started his training in NICBT that time. He was dedicated person. Hassan joined there as a MS course, and then he and Hassan and our Jahangir, he was basically trained in Jahangir Kabi is trained in congenital. Then because of the necessity of the nation, the coronary case is much more. So he diverted to adult surgeon. But he was trained in congenital surgeon. We did lot of cases with Jahangir Kabir. And then Hassan, and both of them trained in Madras Medicine. I should mention the Cherian's contribution in this congenital heart surgery in Bangladesh. He helped our surgeon, cardiologist training and the surgeon surgical training. Then Sharifuzzaman went to there is a course with Dr. Iyer, and I have no idea where Salim took his training in, because I had to. Yes. So this is, I personally, I went to Great Orphan Children's Hospital for training in cardiac anesthesia in Pediatric. I was there for 6 months. I trained myself there, and after that I went to Driscoll Children's Hospital, USA. So how to do that? That time even the venous catheter was not available. No CBB catheter was available. We put 2-3 IV cannula for central line monitoring and for inotrope. That is our era. So still we are poor. He showed the slide. In one hospital, the manpower they have, we don't have in the total nation of 17 crore people. So think about, pick up some guys who was dedicated, because everybody cannot come to these pediatric service. It needs patience and dedication. But if those who look for money, this is not their subject. So I request everybody, try to do more, because we are just far away from what we need. So this is my request to younger, because I am 68. So I am declining in my career. So I will request young generation, please come to this children's service and do more. And I hope. Thank you very much. Thank you again, the American team. Thank you.
We have limitation in time. Still, then I should say something about this session. Okay, we started with ether anesthesia. 2 giant strong men is necessary to induce open ether anesthesia for the patients. From there, we are now in advanced situation. Our anesthetic services are really good to our country, but the total number of anesthesiologists is less. What Hubert had said, there is time to grow up. We have few cardiac surgeons started from SR Khan and Nabi Alam. We are now more than 160. We have a hope. There should be some dedication, not making money. I refused invitation from Jahangir Covid that I will not leave pediatric cardiac surgery. I will be here. Selim also had. Sharifuzzaman also had. Shamsuddin also had that same vision. They sacrificed their life for pediatric cardiac surgery. They don't require money. I may be mad, but these all peoples are not mad. They have some IQ. Of course, there should be some more dedicated persons. A.K. Azad. Is it really so? Yeah. Some more people will come to learn pediatric cardiac surgery, establish them as a surgeon, pediatric cardiac surgeon, without having luxurious flat and cars. They will live peacefully. But our deficiency point is, Nurul Hassan had said, we require more established intensivist nurses and ancillary supporters. I can remember at the last part of the night, one staff coming with a trolley, carrying all sterilized tubings. He changed all the humidifier and tubings throughout the time and taking the first step on. Someone is working in the midnight and cleaning all the linens from the ICUs. Some should be devoted for it. Some should be devoted for these midnight works, late night works. And all the day, there should be recyclable staffs. Number of staff should be there. We need more funds to maintain this type of ICUs. We have only one center where we can say that neonatal surgery to be done in National Heart Foundation, because they have, at least they have some number of intensivists, ICU staffs, pediatric cardiologists, and surgeons to do this, support these things. Funding for neonatal and pediatric cardiac surgery. Look, what Selim is doing here, something like 2.5 to more million. Yeah, more thousand. Yeah, but it requires more than 400. It requires more than 400K to maintain a pediatric case. This is coming somewhere, somehow charitable, sacrificed, and low-paying cardiac surgeon and other staffs. We should mention that we had started our cardiac service from fund from JICA. We had failed to continue their collaboration system. We had requested JICA to establish another hospital, but our political system is so bad. And Shanji Sanu had failed to set a footings here. Our staffs, our government staffs are bad to maintain this. Other collaboration system was Kuwait Charity. They were supposed to establish one hospital, but ultimately we had failed to contact continuously. Like other Friends of Bangladesh, Doctors Beyond Borders, Friends of BD Bangladesh, Korea, they also had set some footings here, but failed to continue helping us. The receiver should be acceptable. Otherwise, this type of collaboration will not continue. I got one information that Japan-Bangladesh Commissioner they are starting another cardiac and neuroscience institute in Gazipur area. Some 24 acres of land government had allotted for them. They are working silently. I think that also will be a good venue for neonatal and pediatric services. Now, I should thank our American friends. They will continue their training program through Rokanujjaman Salim, and also, should I mention your name? You should continue this thing. That will be very good for our country, for our nation. Personally, I should request Nurul Hassan. You had presented your first case, the RB2PA conduit. Can you say again the total diagnosis? Should there be alternative treatment procedures?
I think you can discuss those things later on, sir.
Yeah.
Actually, we're running short of time, sir. I think you can conclude it separate. The clinical.
What is the name of that operation?
Rastili, I think Rastili, I guess, right? Rastili.
No. RB2PA conduit. They had not closed BSD. Yeah. Sano procedure. You should honor that great man. Is the chief coordinator of JICA now. Thank you, audience. This is probably one before last session. You please wait here. The next session is coming. Now we are giving crest to everyone. Thank you, all the presenters here. Yeah. Now we are presenting the crest to the presenters. Humayun Kabir, please come. Professor Khalilur Rahman sir will present. Humayun Kabir. Dr. Sharif Hassan will present to Khalilullah. Ibrahim Khalil. The last crest goes to Nurul Akhtar Hassan. Yeah, sure. Jahidul Islam will present the crest. And this is the last part of our present situation. Thank you. Thank you.
Okay. Without any further ado, let's proceed to the final session of today's conference, which will be chaired by Brigadier General Professor Dr. Mujibul Haq, Chief of Cardiac Anesthesia, Square Hospital. As panelists, we have Lieutenant Colonel Dr. Ashfaq Ahmed Khan, Associate Professor